Hi guys, so we're going to do carcinoma cervix now, and I want this to be a quick lesson. And since we've already done so much of carcinoma cervix, it should be second nature. The most important thing over here would be carcinoma cervix. The most important thing definitely over here would be this one, the staging of carcinoma cervix. Okay, so let's see what are the questions that are asked. Quickly. Oh, nice guy. Carcinoma cervix. Okay. So the headings important carcinoma cervix is etiology, risk factors, signs and symptoms, diagnosis, FIGO, screening, and treatment. Okay, should be very easy. Apart from this, we have explain staging with the help of diagrams. Discuss the methods of screening. Yes, screening is very important. Enumerate the complications of radiotherapy again and again. Radiotherapy complications. I think we already have a video on this. Come on, we got this. Cervical intraepithelial neoplasia, CIN. Pre-invasive, micro-invasive. Then we have dysplasia of cervix, low grade, screening, visual methods, colposcopy principles and indications. Colposcopy, principles, indications. Then we have conization, very important. Verdine cystectomy, hysterectomy. Then we have sutures removed in Verdine, management of pubertal dysfunction, uterine bleeding, downstaging of cervical cancer. I have no idea what that is. Let's see, downstaging. Then we have epidemiology, risk factors, HPV, Bethesda classification. We have HPV, cone biopsy, conization, staging, Verdines, treatment of stage 4 cancer, survival rates, HPV, survival rates, and this one on adenocarcinoma. So this pretty much covers the section for us. Should be 100% done for the exam. See, when I want to revise it, how I imagine myself doing this would probably be, so our revision is starting from the first, right? So from the 1st till 19th we have a few revisions. So it will start with PEDS, OBG1, OBG2, surgery ortho, surgery 2, PEDS, OBG1, OBG2, surgery 1, surgery 2, PEDS, OBG1, OBG2, surgery 1, surgery 2, PEDS, OBG1, OBG2, surgery 1, right? Surgery 2 cannot be done. Fine, that much should happen. And once 15th is over, medicine 1, medicine 2, medicine 1, medicine 2. So twice medicine will get over, and PEDS, I think this once, twice, 4 times you'll be able to revise the rest. So that should be more than sufficient, but you should give your 100%, okay? So Yeah, let's go for the short this one. So cervical cancer, cervical neoplasia, blah 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 blah. So let's quickly just go through. Let's just go through the this one. Uh, quickly, let's just go through. Quickly, let's just go through the textbook, the notes, and then we can see. Okay, most common cancer cervix is it's most common in the transitional zone form, followed by squamocolumnar junction. Most common variety is squamous cell carcinoma. Second most common adenocarcinoma. What's the lymphatic drainage? The lymphatic drainage drains into the sentinel lymph node in carcinoma cervix. That is paracervical lymph nodes followed by parametrial lymph nodes, which paracervical lymph nodes drain into the obturator lymph nodes, which then drain into the external, internal, and then common iliac lymph nodes, and then para-aortic lymph nodes. Okay, paracervical, obturator, iliac, para-aortic. During hysterectomy for carcinoma, always remember superficial inguinal lymph node involvement is always stage 4 carcinoma. But it's if see a few things about this one. Anytime there is superficial inguinal lymph node involvement, it will come as stage 4B. It's like metastasis. And one more point about this one. I think I have it here. Superficial lymph node not included in pelvic radiotherapy for carcinoma cervix. Okay, and it is these nodes not involved, not included in radiotherapy. Why? It's not included in radiotherapy because it's usually not effective. Paracervical and parametrial. Say again. Paracervical and parametrial lymph nodes are the most commonly affected lymph nodes. Pelvic lymphadenopathy is seen. Why is pelvic lymphadenopathy seen? Para-aortic and rectal lymph node also we need to dissect. Why? Because from paracervical it can go to uterosacral, rectal lymph nodes. Say again. From posterior cervix it can go to uterosacral, can go to rectal lymph nodes. Okay. Superficial lymph node not involved. If involved, stage 4. Opposite is true for vulval cancer. Vulval cancer, superficial inguinal lymph nodes are the first lymph nodes, sentinel lymph nodes to be involved. Here, sentinel lymph nodes, again, sentinel lymph nodes in case of sentinel lymph nodes in case of carcinoma cervix is paracervical and parametrial. Right? Whereas in case of vulval cancer, vulval cancer, the lymph node is superficial, inguinal is the sentinel lymph node. Yeah, so when we reach the lymph nodes we finished. After that we go for not included in staging, but if there is Lymph vascular space involvement is a poor prognostic marker. So do you know any poor prognostic marker which is not involved in staging, but if it is present, it can cause an issue? Yeah, it is uh, lymph vascular space involvement. What is the clinical presentation of carcinoma cervix? Most common presentation that we know is postcoital bleeding or contact bleeding. But the most common is irregular vaginal bleeding, then followed by postcoital or contact bleeding. So again, this is all very clinical points which I really love, and I really wish you all could like make sure to not miss out on when you are presenting the cases. So in clinical point, most common is irregular menstrual bleeding. Most specific is irregular menstrual bleeding, but most specific happens to be contact or postcoital. Okay. So after this we go to the next point. Lady is presenting with postcoital bleeding. What's the approach we had there? We do a perspecular exam. Grossly, if we see it is abnormal, we are going to do a punch biopsy and endocervical curettage. If it is really normal, we do a pap smear, we check for colposcopy. If it is a visible growth, we do a punch biopsy. Okay. So what is abnormally looking? Abnormally looking means we suspect barrel-shaped cervix. We have cervical indurated cervix or a firm cervix. Let's see if we have an image. Adenocarcinoma cervix. Cervix in perspeculum. Okay. Now this is adenocarcinoma cervix. See, cervical carcinoma. Okay. Not sure if you can get an image, but yeah. So if you have a barrel-shaped cervix and indurated cervix, firm cervix, it is a adenocarcinoma of cervix. So you can take a biopsy from any part of the cervix other than the meibomian cyst. High risk? Who is at high risk? HPV patients are at high risk. Why it causes this? Mutation. What does HPV cause? See, HPV is it goes and attaches to elongation factor. It helps them to circumvent the cycle. Correct? Do we have a very good explanation for this magnitude of the problem? I think it's here. Prognosis, staging, genital pre-malignant lesions and pre-malignant lesions, carcinoma cervix, CIN, yeah. Vulvar carcinoma, treatment of CIN, pathogenesis, HPV infection, yeah. E6, E7 oncoprotein expression, which causes degradation of P53 and is E6, E7 elongation, which causes proto-oncogene expression, which in turn causes which in turn then later on in later stages P53 and retinoblastoma are affected. Okay. Carcinoma cervix, the most common cause of most common cause will be breast, colorectal, lung, carcinoma cervix. Breast, colorectal, breast, GIT, lung, carcinoma cervix. What's the most common spread? Lymphatic spread, paracervical and parametric, then followed obturator, then followed by external, internal, common iliac, and then we go to para-aortic group of lymph nodes. Most common site of hematogenous spread will be to lung, ovary. Okay, no need for oophorectomy. Why? Because the spread to the ovaries is a very, very rare thing. So what are the prognostic factors in case of... I don't have time. So most important prognostic factor is staging and lymph node involvement. What are the investigations you are going to do? So we have investigations, cerclage, management, radiotherapy. What I definitely want to do is cervical intraepithelial neoplasia, but I think that's a long... This one. How long is it? It's a lot of understanding, but probably 88 and 70. 158. 76, almost more than 1 hour. Let's see if we can manage it. So yeah, coming back to more specific, prognostic factors, staging and lymph node. Staging and lymph node. So this many points, I hope it is very clear for you. So remember, flashcard. Prognostic for cervical carcinoma is lymph node and staging. Okay, so this much is done. Alright, so let's go to the questions. What's the magnitude of the problem? Is the leading cause of cancer and the cancer related in worldwide more than this many recorded annually? More than 85% of this occur in low middle class income. India is a major public health problem. India cancer is the second most common gynecological malignancy. So then what would be the first probably? Breast carcinoma, very good. It is expected to improve with organized screening program. Pap smear has reduced the incidence of cervical cancer by nearly 80%. HPV vaccine is safe and effective. It is expected to reduce the incidence by 90 to 100%. Cervical carcinoma is an entirely preventable disease as the different screening, diagnostic and therapeutic measures are effective. Improvement is needed in case of economic resources. It needs changes in culture, implementation. Disease could be treated in pre-invasive phase as it lasts several years before it becomes invasive and curable. So in magnitude of problem, what and all did we understand? Let's say incidence. So, in India, 12 population-based cancer registers show breast cancer most common carcinoma. Among female cancer, relative proportion of cancer breast varied between, whereas that of was 14 and 24%. In India, an overall incidence of 23 per 1 lakh has been observed of carcinoma cervix. Okay. So if I had to give any introduction to any long answer I got of carcinoma cervix, it would be in epidemiology. Let's say in India the prevalence is more amongst the comparatively younger group, 45 years. Carcinoma cervix is rare in who are sexually not active, non-virgin women, and male circumcision partly protective against cervical carcinogenesis. Okay. In epidemiology, we have to say simple thing. Epidemiology, it's a second most common gynecological, this one, fourth most common in females, and it is almost 23 per 1 lakh. Okay, this much is done. It is highly preventable, highly treatable, highly preventable because of screening, diagnostic, treatment, and HPV vaccine and pap smear. Correct? Pap smear has brought it down by 80 to 80%. It has reduced the incidence. This much is enough for epidemiology. Okay, and it has slow progression. So for epidemiology, then in gross pathology is not a question. Etiology, risk factors, signs and symptoms. Where is the etiology? HPV here, risk factors. Yeah, I definitely think we have to finish this on cancerous lesions before we can start. So I don't think I have 88 minutes. So probably we could just, how many pages is the notes? 10 pages and 22 pages. Let's see whether in half an hour we can finish writing it so that we have a good understanding of the notes. So, cervix, yeah. Relevant anatomy, we have endocervix, ectocervix. Okay, we have an endocervix, we have an exocervix, not ectocervix. And endocervix is called supravaginal part, and exocervix is called portio vaginalis. Okay, we have an endocervix, we have an exocervix. Endocervix is lies close to the uterus. It's called supravaginal part. It's lined by columnar epithelium. It's derived from the Mullerian duct. It's red and velvety. This much you need to remember. It's red and velvety. Then we have the lower part, that is exocervix. Exocervix lies within vagina. It's called portio vaginalis. It is lined by non-keratinized stratified squamous epithelium. It's derived from the urogenital sinus. It's smooth and pink. So what do you call the top one? Red and velvety. What do you call the bottom one? Smooth and we call the above one red and velvety. This one was smooth and pink. This much you should remember. The epithelium will probably remember. External os is the cervix, where the cervix opens into the vagina. Okay. Cervix is derived from Mullerian duct. We know that. The epithelium of urogenital sinus is non-keratinized stratified squamous epithelium, which replaces the urogenital epithelium. So red and velvety, pink and smooth. The migration occurs only up till external os. Okay, so there is a migration. So now we're going to learn the concept of transitional zone. That's something else. See, you really got to push. It's going to be totally fine. We can write this up and we will definitely finish it. Okay, in another like an hour or so, and then in another 45 minutes we can finish up this whole section.